movement with our host, Dr. Jack Rocco. Dr. Jack, how are you? And you like to bring on these amazing experts to provide such value for men, because that's your goal, to serve men, isn't it?
Absolutely, Neil. And John had such a resounding response after his last appearance here on the Ultimate Men's Movement. We did our last talk about shoulders and shoulder health, and I think we got good response to that. And I think I personally also liked the fact that we were able to merge in the orthopedic carpentry along with some discussion of wellness, longevity, health versus illness. So we decided to go with another one. Today, we're going to be discussing knee arthritis predominantly, but also the effects of weight, the effects of high BMI, metabolic disease, and testosterone in that development of knee pain and knee arthritis, which may require knee replacement. And I think there's definitely a lot of interconnecting weight management and knee replacement conversations that we can have. So welcome back, John. Thank you so much for taking your vacation time to spend a few minutes with us here on the movement.
Anything for you, Jack. Resounding response, notwithstanding, anything for you.
You are my best man, John. I don't think we mentioned that the last time.
Yes.
But, so you are up vacationing on Lake Erie, correct?
That's correct, Jack. Just a little west of Ohio, going towards Geneva Lake. You're familiar with that?
Yeah, you're not far from me in Mentor, Ohio at all. So Mentor on the lake. So we're not far at all right now.
Yes.
Okay.
I can sense that. There's a close vibe going on here.
All right, John. So let's get started. Let's talk about knees. And I think we're going to eventually go into knee replacement. But you are a sports guy. You do cover everything from knee scopes, ACL reconstructions. I don't know if you do multi-ligament reconstructions anymore, but through the process of degenerative knee arthritis and total knees. Now, what are you seeing in your practice with regards to the knee and knee pathology?
I think, Jack, the topic of this conversation and this podcast is very applicable to what you're referring to with the, I won't say older, but I'd say middle-aged male who is a little bit overweight. Maybe I'm talking about a 45 to 60-year-old who tears their meniscus, has a little bit of arthritis, you scope their knee. Not the worst knee in the world. Not, oh my God, this guy needs a knee replacement, but they still do well afterwards. They limp a little bit. They're a little swollen. They don't get better as much as they wanted to. And that's a very unhappy subset of patients. Unfortunately for all of us who do this for a living, a very common subset of patients. And how to make that patient better, for lack of a better term. Weight loss, body optimization, body fat optimization can make someone not have a less degenerative knee, but certainly feel better.
Yeah.
And that's what we're in the business of doing.
John, I'm not sure how much we talked about this, but I had a very intense exposure to the idea of generalized inflammatory arthritis during the pandemic. I believe it was related to the vaccine. During all of COVID, I worked every day. I never once had symptoms of a flu, of COVID, of anything. I never tested positive, but I had my first vaccine in January, had my second vaccine in February, and April, I went golfing one day, and after golfing, my right knee, which was the knee that I've had, you operated on my right knee one time. I had a knee replacement.
And I've seen you golf, so I can understand.
My golf swing is not conducive to a bad knee. But anyways, after golfing, my knee started swelling. Like I started getting an effusion. And at some point I told my PA, I'm like, this knee is going systemic for me. I was a little perplexed. And I'm like, my kids were coming in. I drained my knee. She even injected my knee with some cortisone. And I was feeling systemically, I was feeling pretty bad. And I asked her she put me on a Medrol dose pack. I'm not a big fan of steroids, but I went on a dose pack, and make a long story short, eventually I ended on systemic steroids, oral steroids, for about 6 to 8 months. Like, it went completely systemic. I couldn't lift my shoulder to shave my head. I couldn't get out of bed. I used to have to keep my arms at the side because I couldn't lift to even push from the bed. So I would roll to the side and do one of those log roll maneuvers. I went through a rheumatologic workup. My SED rate was 86, which is extremely high. My CRP was elevated. I forget what that number was, but the SED rate being 86, I remember from our training in school, 15 is maybe the top normal. for rate. What we were taught or what often seen was that this is someone who had a very systemic, deep-seated metastatic cancer,
New infection or a severe inflammatory reaction.
osteomyelitis, something deep. So like I said, I was at 86, which was impressive, and I could feel it. Like I was sick. I was systemically sick. And a lot of that went into some of my considerations for options for careers. I'm trying to fix shoulders and knees and hips, and I'm having my own shoulder pains. The thing that amazed me about it is that it was the inflammation in my body which caused the knee pain. We typically were more mechanically oriented, where you have a bad knee, you have an injury, it creates inflammation, you have knee pain. But for me, it ended up being my whole body. And I said, it was this inflammatory reaction to whatever.
It manifested in you as knee and shoulder pain. It was total systemic inflammation.
Correct. And it comes into play, I think, with a lot of these. I would look at the patients that we have as knee replacement patients. You can put them into two broad categories, obese versus non-obese. And a lot of times you'll see that guy who still has good muscle mass. He's not overly obese, former athlete or former blue-collar worker who's got the bowed legs. He's got really bad knees, but he may or may not have knee pain. And then you get some of these patients that are a little more obese who have not horrible looking knees on x-rays, but a lot of pain. And I think
that's what I was talking about.
Yeah, now I'm getting my point of this subset of patients that are morbidly obese. They've got BMIs 30 to 40, and the knees aren't necessarily that bad. They didn't necessarily have any injury, but it is a systemic disease, really, that's manifesting as some of their knee pain. And when you see those patients, some of them, they may or may not qualify for surgery because of their BMI. You'd like them to lose weight because you don't want to replace the knee in someone who is, the heavier you are and the younger you are, the more likely you are to result in loosening and revision. What are your thoughts on all that?
Well, my thoughts are right along yours. And I would tell you, like I stated earlier, our job is to make people better, right? We can replace knees and have the most beautiful x-ray in the world and good looking objective findings, good incisions and things like that. But some people don't get better because you didn't treat the underlying problem, which sometimes is not the arthritis. It's the inflammatory response. And so, yes, you have to figure out what is causing the symptoms, whether it be worn out joint, bone-on-bone arthritis, or is it that overall inflammatory situation going on that's not going to get better with surgical treatment?
Mm-hmm. No, it's interesting, guys. I struggled with knee pain young. I was a high school, college basketball player, tall, lanky, really didn't work on muscles. So I probably, if I would have done more, I started lifting after pro wrestling, starting to make my journey in pro wrestling from basketball when I was only like 220 pounds. So I lifted some, but I always had knee pain and I tendonitis in both knees really young. What is that? How does that manifest?
Go ahead, take this one, John.
Jack?
You're the sports guy.
Okay, I would take that. Yeah. Multifactorial. A lot of it is height weight discrepancy, the tendon length that you have being, you're 6'10" or something like that. You said you're 6'9".
6'10".
And yeah.
So I was 6'9" then when I was in high school. And I went through knee pain probably from 6'6" to 6'9". And my knee pain probably didn't go away ever till I stopped playing basketball.
So some of it is the classic growing pains where you have a growth plate that's open and the physis gets inflammatory and irritated the growth plate. Some of that is from the stress of long tendon length. Orthopedics is applied physics, right? So you have lever arms and pull. And if you're not strong enough, if the strength isn't there to equal the lever arm that's being pulled on by your height and length, then you get pain associated with it.
Absolutely. It's amazing when you
have the strength to go with the size.
Yeah. And what I found too is that when you treat a lot of those young kids that are going through growth spurts, they come in with these vague, it's the old Osgood Slaughter's disease of the knees. And
Apophysitis.
Pardon me?
Apophysitis. Seavers, Osgood Slaughter's.
Yeah. But you see these kids in the office and these are healthy kids. They're athletes. And when I see them, a lot of times I'll ask them to touch their toes. And it's amazing to me how inflexible they are because I say their feet have grown away from their fingers. As they're growing so fast, the bones have lengthened, but the tendons haven't quite caught up with the bones. So they're surprisingly tight hamstrings, tight quad tendons. So that's usually a stretching thing, and not necessarily any issues with the joint per se, just it's the surrounding tissues from it. But the population, like you said, the more difficult, that tweener group, that group that's in no man's land. They're too young they don't really need a knee scope, they've got a little bit of early arthritis. They've got maybe a little bit of meniscal damage, a little bit of just wear and tear in the knee, but they're not quite ready for a knee replacement. They're a little overweight. They're a little out of shape. That's the wheelhouse of the men's clinic, the guys that you're trying to get more longevity on their knees and improvement. And what do you do with those guys? Are you doing cortisone? That's a lot of the hallmark, but...
Yeah, frankly, Jack, your clinic is in the wheelhouse for that patient for a number of reasons. Some of it is they're just out of shape and they're unhappy, right? They're unhappy. They smoke too much. They drink too much. They don't sleep enough. They hate their job. They're unhappy and they manifest some of this stuff as pain, right? Joint pain, this or that aches. And if you could make them happier, healthier, equals happier, right? You can make them healthier from a weight standpoint, from an exercise standpoint, stop smoking, don't drink so much, sleep better, which is huge. Suddenly their knee pain isn't so bad. Right. That's a lot of it. If you can cure those things, not even touching their knee, they get better.
Right.
Markedly better. Short of an obvious structural pathology, big fat meniscus tear, bone-on-bone arthritis, those things that we dig into as orthopedic surgeons with knife and fork. But it's those middle ones that you're talking about. They're just unhappy people with lots of things going on.
And if you send any of these guys for an MRI, guess what?
It's going to show something. And
you're going to
embed on something.
Right. The MRI report is going to come back partial tear, posterior horn, medial meniscus, some degenerative partial tearing of the ACL. Like everything is just frayed and tattered, but there's no proof that any of it is causing their symptoms. So you could, you have a tear. As soon as someone sees a tear on the MRI report, you better fix that tear. But once again, if you refer to that tear as just some fraying or degeneration, some softening, there's different words that can be used. They're micro tears. They may be intrameniscal. They don't come all the way through. So there's definitely a lot of, and you can scope those people all day long and they're going to come back. They're still miserable. And then they hate you.
Get better. And you can attest to this personally, but just in general, people want an easy fix.
Right.
My knee has a tear. You as a surgeon, scope me, fix me, then I'll be better. Well, sir, you need to lose 20 pounds. You need to sleep better. You need to do what's a lot of work. I don't want to do all those things.
That's the mistake right. Our jobs, like marketing, overnight I'm going to get all these sales. No, it's a process. Same thing when you talk about what you do. Okay, doc, you're going to put me under the knife and I'm good to go. No, you're going to have to do rehab. You're going to have to put time in. And you have to make sure you don't screw it up again because you could re-injure it. You can re-aggravate it. It goes back to the people you guys see, your patients. Some of them really want to take action. Some of them don't. And that can become debilitating in the medical field.
And then, like you say, John, you're right. This is in a lot of ways a perfect patient for something non-surgical. You don't necessarily want to be in an orthopedist office for that, because if you're in an orthopedist office long enough, and if you go to another orthopedist and another orthopedist,
someone's going to operate on you.
Eventually, someone's going to operate on you. It's just the reality of it. You'll find someone
the way
willing.
Business work. That's how you make money, right?
Yeah. Right. And it's a coin toss. Certain percentage of the time it's going to work, certain percentage it's not. But so then the idea of the excess fat, and let's get into testosterone. For me, when I went through my episode, I was not on testosterone. I had been on it before, but then I stopped it. But I knew at the time that testosterone is a good anti-inflammatory. Not only is it a good anti-inflammatory, evolutionarily, if you look at it, if men are out there in battles, they're constantly getting wounds and injuries and this and that. And their higher testosterone may help heal some of those things by reducing the inflammation. But also the way that it affects fat, especially visceral fat. If you can get some of these guys to lose some weight, to gain some muscle mass, to have more support and strength around their knee, to be able to walk downstairs without wobbling, without being weak, to be able to kneel down to pick up your socks without having aches and pains, something as simple as that may help your knees. It's not what you would necessarily think of as a first line, but there certainly is a lot of improvement with that. And I'm at the point now, it took me a good solid year to get through all that inflammation. And I still had some tightness in a few of my joints, and my finger wouldn't go down all the way. And it was disruptive. I did one PRP injection in my knee, which did seem to help. And that's one of those, same as cortisone. It may or may not work. It may or may not be doing anything. But for me, it was worth it. I had a PRP injection. And then recently I've been on some supplements which really treat a lot of the inflammation. And I'd say in the last 4 or 5 months, it's a product called Tri-Synergizer. And it's basically a systemic anti-inflammatory. It stimulates RF1, NRF2, NAD. It helps with a lot of this revitalization. And I've also mixed it with some collagen, which I think is important for all those things that we talked about. You need some collagen for repair and for regeneration. So you're right. It was
Those wrinkles on your forehead, Jack. You got to do something about those wrinkles on your forehead too, a little collagen.
I've always had those, but that's because I'm always concerned and worried. That's my worry lines there. Yeah. But you can do injections, that kind of stuff. My point being that if you look at my knees, because I had an ACL when I was in college, and I had a second surgery after that in Pittsburgh for stiffness, and then you did my third surgery for a degenerative meniscal tear. But if you look at my knees right now, you put those up on an x-ray box or a computer screen, any orthopedic surgeon in the world is going to say that guy needs a knee replacement. But guess what? I've got minimal to no knee pain.
Wow. That can be huge for athletes. Wouldn't you agree, John? Especially the ones like me dealing with it when I was 16 and 17. If I wouldn't have that knee pain, who knows where I'd be playing?
Sure we do. NBA, baby.
Yeah. So it's the knee replacement is a great surgery. There's no doubt about it. But this is one thing that I could maybe be on the side of some of the insurance companies. You do need to go through a process of non-surgical care before you jump into a knee replacement. What do you tell your patients on when is it time to get a knee replacement in your hands, in your practice?
So joint replacements in my practice are based on several factors. You have to have the structural pathology. You have to have the bone-on-bone arthritis, number one. You have to have a motivated patient who's willing to understand what it takes to get through a joint replacement, not only the surgery itself, but the rehab afterwards. And you have to be able to match up the findings on x-ray with the patient's complaints, because sometimes they don't quite match up, and that it's always a red flag. It's where they hurt doesn't match where the x-ray says they should hurt, or how they hurt doesn't match up. You get some of those patients with the x-rays that aren't quite that bad. And, oh my God, the pain's out of proportion to what we've all been fooled, Jack, over the years. You operate on that guy because they come back and you fall for it, right? Say, okay, we're going to do that. And then afterwards, oh my God, they're terrible. And their pain's not better. And it's worse now. And, oh my God.
Especially a lot of these guys, I've done that in my practice, where you take a younger guy and you're like, look at this guy's x-rays. What's your diagnosis on this lady's x-rays? What's your diagnosis? She's like, oh, she needs a total knee. And I'm like, the finger says that she's got patellar tendonitis. You touch this high-tech tool right here.
Examine the patient.
Which is attached to this incredibly refined software up here. So you got the hardware and the software. That's how we grew up doing orthopedics. But if you look at an x-ray, you look at a bone scan, and you're right, if the finger doesn't correlate with the high-tech findings, you're going to get burned and the patient will be harmed. What do you do with your patient? Say you got a patient that's got a BMI of 40, 41, and you do think they need a knee replacement. That's a high-risk patient, correct? For infection.
Well, certainly the literature has suggested that over 40 have an increased risk of infections, wound problems, everything actually, because they don't mobilize as easily. With a hard number like that is, there's a 40 BMI patient who's, for lack of a better term, a fat slob. You have 40 BMI patients who are rock solid dudes who are just muscular and just they're heavy because it's height and weight. There's no body fat analysis in that, which is a mistake. Because we mentioned weight loss earlier, and it really isn't necessarily weight loss that improves these people. It's body composition change. More muscle mass, less body fat ends up being more weight, usually. It really should be a body fat percentage in there somewhere for BMI.
No, you're right.
And this is one that will go viral on shorts. And let's have your take, both of you, on BMI. I think it's not a great way to measure things. Like I go to the doctors and say, you have an athletic build. And we're not going to look at your weight at all. We see it. You have an athletic build. You don't have much fat on your body, but yet it's muscle. weighs more than that, so you're carrying a lot of weight. I am on my spare tire is almost gone completely in my reverse aging process from about 4 years ago. And I've gone through that journey, but I'm like, dude, I can lose weight, but I'm not looking at, oh my gosh, I need to lose so much weight so I look like Skeletor. And so I look at all these things, and I said, also, when I start to do more yoga, strength yoga, I gain weight, but I not gain weight in the wrong way. So I think this BMI thing needs to be. So what are your thoughts, both of you, on BMI?
Yeah, I would agree. And I'm glad we didn't talk about this earlier, John, and we haven't probably ever had this conversation in all our years of friendship. But exactly what you say, the patients that you see, that I have so many patients in my head that have BMIs of 41, but they're former football players. They're very muscular guys. A lot of them are African American. They look in good shape, and they've got horrible knees, and they would probably do well with a knee replacement, but they don't qualify, or they get knocked off. But then you've got these other people, they're like, her BMI came back, it's 34, 36. Like, those patients, to me, in my experience, are higher risk than the guy the former football player that's a 41. What would you say on that? You agree?
I agree. I think, to Neil's point, BMI is not a great thing to judge on. They use it because it's out there. Height's easy to measure, weight's easy to measure. There's tables available, and so they use it. Why they don't use body fat percentage? Because that's easy to measure in today's day and age. It's a cheap scale you put in your office, and it's easy to measure. So I think they should add that in there somehow. I don't have the statistics to determine what the number should be, but certainly it's more valuable to me than height and weight.
No, I agree 100%. And
risk and outcome.
You get stuck in this situation where some people, for lack of a better term, need a knee replacement. First of all, I don't think anyone needs a knee replacement. I think it's still an elective procedure. It's something you want. There are other options, but some people get to the point where they've failed non-surgical care and they're over the BMI limit. So insurances won't approve it. So those people are, I think, really the very sad cases. They can't get the care. And what is the other alternative? Putting them in a scooter? They said if you have a choice between getting a knee replacement and going in a scooter for the rest of your life, and it's almost a death sentence. There are some patients that are at that, it really pulls at your heartstrings. You're like, I can't do the knee replacement. You don't qualify. You got to lose the weight. And it's very hard for them to lose the weight.
Now you're going down a road of the Wegovy's and the semaglutides and the different weight loss, which are effective. They're, no question there. If you can get them approved, people lose weight.
And then gastric bypass. So you're adding another.
It ended up being a terrible operation, in my experience.
Yeah.
You can't undo it. You
No.
can go on Wegovy or Ozempic, lose whatever you have to lose, have your surgery, come back off of it. Hopefully you improved your lifestyle, improved your eating habits, and improved the secondary things which are healthy for you. And you come off of it, done.
Yeah. You can get their, exactly. You can get their weight down with those semaglutide GLP-1 agonists, but they also lose muscle mass, some of these patients. There's a muscle mass loss, and you need the muscle for the surgery and for health and for balance and for longevity. So there's no utopia, John.
You're 41, you can't have surgery. You're 39 and a half, you can't have surgery.
And you're right. The physician judgment, unfortunately, has been taken out of that.
And they'll say, we don't practice medicine. You can do the surgery, we just won't pay for it. The patients can't afford it.
Exactly.
Yeah.
All right.
So, Jack, we've had a great conversation. I think that BMI thing is going to definitely get people going, especially in the medical field. Where do you think the best thing focusing on a knee replacement? I'm going to ask that last question. What's that measure, that marker that you definitely need a knee replacement?
Yeah, I think that in my opinion, I would say John's the same. I think we're trained very similarly. When you get to the point where your knee tells you that you need a knee replacement, you've done everything else. And I do think for men, the possibility of testosterone replacement, it's worth taking a look. If they've got a low testosterone, if you get them on supplementation, you can maybe get rid of some of that belly fat. You can maybe improve some muscle strength, and their knee pain may go down. You need 100 patients and do a study on it, which doesn't necessarily exist. But like I say, personally, and some of the stuff that I've seen with friends and colleagues, by improving your muscle mass, by reducing your belly fat, you're putting less strain on your knee. So just naturally, you're going to have less knee pain. So for that 40 to 50-year-old patient, 55, 60-year-old patient who's not quite ready for a knee replacement, their knees aren't that bad, but they're still miserable, I think to check their testosterone wouldn't hurt. Consider supplementation. It may certainly help. What do you think about that, John?
I agree with you. To answer your question more directly, you consider knee replacement when the pain in your knee affects your lifestyle and the ability to do your activities that you want to do, whether it's run, bike, walk, play with your grandkids, walk your dog. This that you want to do, you can't do it anymore because your knee hurts you so much. And you have knee arthritis. And you've failed other things, the injections, the anti-inflammatories. That's the time to consider knee replacement. Now, Jack's point about the testosterone replacement or optimization really is very valid, whether you need a knee replacement or not. If it can help you avoid a knee replacement or postpone a knee replacement, great. Even if you're going to have a knee replacement, optimizing your testosterone will help you optimize your rehab afterwards, your prehab beforehand, and really your total outcome after a joint replacement. No question about it, especially a hip or a knee.
Yeah, actually, one of my patients, that you mentioned that a patient of mine was going for a hip replacement, and we got him on testosterone beforehand. And he's like, my hip replacements, they do have a good recovery, but he swears that his recovery was really enhanced by testosterone. He goes, yeah, I feel great. I've got some strength. I did rehab fine. He goes, it didn't give me a problem at all. It's nothing you're going to find in the mainstream that says, yeah, testosterone, there probably needs to be more studies on it, but it's an option. Like I said, if you're trying to avoid surgery, there are worse options that you could consider. So what else, John?
Great stuff. That's all I have to say.
Yeah, I think it's an interesting topic. And I think my view on it, so when we trained, we were the carpenters. You have a knee, it's arthritic, you replace it. As you mature, as you become a little wiser, as you have some experiences under your belt, you're like, you know what? The spidey senses start talking to you and say, you may not be the best candidate for a knee replacement. Let's try some other things. And you're never wrong trying other things as long as the patient is willing and able, because there are many different options besides just jump to a knee replacement that can help. You made that great point in the beginning. We're there to help people.
Expand your practice. You're there to help the patient.
Right. We're not there to replace their knee. If replacing their knee is what they need, then that's what they need. But if something else is what they need, we have to consider both options.
Absolutely.
Thank you.
All right. So best place to go, John, just look him up. Go to theultimatemensclinic.com in New Bedford, Massachusetts. Appreciate it, guys. Thanks again and great stuff.
Thank you, guys.
All right. That's a special simulcast to the Neil Haley Show and the Ultimate Men's Movement, guys. Take care.